just to give a little bit of the background, I mean, many times people don't think as far as stigma and discrimination in TB. But the reality is that people who are being treated for TB or have undergone treatment of TB are really, really discriminated against. And those of us who work closely with the affected communities would know the kind of disastrous effects that can have. I've seen more and more young women who come to me and say either their engagement has broken, their marriage is broken, they've been thrown out of the house, they've lost a job, all because they disclose the fact that they were either under treatment for TB or that they had had TB some time ago. So we know that even though scientifically, I don't see any of the doctors here, oh, except for, yeah, all right. Well, kind of, you know, I meant, no, I was going to say scientifically, even though, you know, TB affects men and women both equally, but we know that the way it affects women is really, really disproportionate. The kind of effect, the social kind of things that are around TB that affect women are much, much more, you know, have stronger, worse consequences than it does for men. So stigma and discrimination is very much there. And if you ask me, it's much more in TB than, you know, I know we said we shouldn't compare, but, you know, we learned about TB and, about stigma and discrimination with HIV. I mean, we didn't know about these words before HIV. But 20 years ago when HIV happened and we all kind of got onto that community-driven response, we learned what stigma and discrimination is. And many times people say, no, 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 for TB there isn't. But there is huge stigma and discrimination. A couple of years ago, I was doing a small study in one of the TB hospitals in Delhi in preparation for a talk I was doing at the International Union. And I was interviewing patients, and I will never forget what this woman said to me. She said to me in Hindi, यदि डॉक्टर साहब हमसे प्यार से बात करें तो हम सब कुछ सह लेंगे. Meaning, if only the doctor spoke to us kindly, we can bear everything else. I mean, she said it in passing, but it really stuck to me. And I said, this woman was co-infected. She was HIV positive. She was being treated for drug-resistant TB. She was thrown out of a job. She was thrown out of her house. She was living with her sister and brother-in-law. She had lost her 10-year-old daughter to HIV, and she had a little baby who she was looking after, who she didn't know whether would survive or not. And then she said, I mean, and in the midst of all this, she says, if a doctor speaks to me kindly, I can bear everything. It really blew my mind. And I said, you know, stigma and discrimination happens at every level, families, communities, and more so from healthcare workers. And I think it's very, very important that we as healthcare workers also recognize that just a kind word, going a little bit out of our comfort zone and caring for the patients actually would have tremendous effects, you know, in actually helping that person complete treatment and adhere to treatment. So women and men also go through this. You know, access issues are there for both men and women, and stigma and discrimination actually perpetuates that continuously. We know that in many countries, women cannot access treatment or other services if not accompanied by a man. I mean, rural India is a classic example of that. And there are others who lose jobs. There are others, you know, like I've said, have broken marriages, engagements broken. And then, you know, in India, there's also this complication of caste. You know, for those of you who understand that, you know, that I have been to villages where children's plates are actually marked with their names and the caste, so that those things are not kept with the other children's plates when you give a midday meal. So, you know, we're dealing with all these social inequalities and iniquities, and stigma and discrimination really, really, you know, that's where there is stigma and discrimination, these inequalities thrive and they, you know, multiply and ultimately actually push patients away from treatment and you know, whether there is scientific evidence or not. this is the reality. And we face it every day. And so to discuss a little bit about that, I mean, I don't need to, I think, make a stronger case. All of you would understand that this is something that happens. And our panelists have great experience in the kind of work they've been doing. So what I'm going to do is I'm going to start off with you, Dr. Keerthi. And I know Vasavya Mahila Mandali has done great community-based work. So in your experience, what have been some of the, kind of glaring stigma and discrimination issues around TB that you have seen? And what are some of the responses that you as an organization have been able to develop to address that?
In Andhra Pradesh, when we started the intervention, especially let me go to when writing the proposal itself in 2009 to defeat, I called one of my frontline health worker. I asked him what are the issues. He told me the first point, stigma discrimination. That time we are working a lot in HIV AIDS. I asked him, is it that much in tuberculosis with regard to stigma and discrimination? He told it's much more in tuberculosis than HIV. That's what our frontline health worker told. That made me to analyze the proposal towards the tuberculosis and stigma discrimination. How do we reduce it? And some of the things which we have seen in our program is one of the women, when I have seen it, she is bony, and she got tuberculosis when she is 18 years old. She is a tribal woman, and she was married at the age of 15 years, and she has been discarded by her husband at the age of 18 years. By that time, she has a daughter also. So, and her own siblings also hasn't made had to come near to them and to stay with their families. Now she is staying with one of our outreach worker. And like that, when I visited one of the families, then I found that one of the boy is got a co-infection case, that's HIV and tuberculosis. He became blind also, and his sister got tuberculosis, and she has been not to come to school. That's what the school authorities told. So she has been taken out of the school for 2 months. And then we have seen in the healthcare setting itself, how the stigma is there. In one of the tribal areas in the DMCs, to keep the sputum on the slides, the lab technician asked the patient itself, the person living with a tuberculosis or the suspected ones, to keep their sputum on the slides. This is how we are seeing the stigma and discrimination at various settings, at the family level, community level, at the schools, and also at the healthcare settings. And how do we respond in our own programs is, with regard to this, we have encouraged the community-based active women and men to come forward, either living with tuberculosis or living with HIV, and from the affected families and the key persons in the communities and the panchayats to come forward and form into adult support groups. And we have educated them on how tuberculosis transmits from one person to the other, and we have also given them the knowledge on how it won't transmit also. Otherwise, no, if we give knowledge only on transmission, how it won't transmit, they think that everything they can apply it. So that's why that has improved their knowledge levels, and they started working for early identification, and also whenever the stigma issue comes in their own families or in the neighborhood, they started tackling it, and they are doing it. And in the school level, what we did is we have promoted a school support group with the children living with HIV and with children with either tuberculosis or from the affected families, and the children from other children from the school, and 2 teachers. And they have started working, giving knowledge on tuberculosis as the knowledge we have given to them. They have passed on the knowledge both through the students and also to the parents, because sometimes the objection will come from the parents also. That's why the knowledge was given to them, and now they became active groups, and they are seeing that all the children are at school, and right to education is, in a right spirit, is being implemented. And at the healthcare setting, we have sensitized both the medical and paramedical staff at the healthcare settings, and now there is a lot of improvement. Still, there is yet to be done so much.
Okay, thank you very much. I think that I'd like to come back to you with the thing about increasing knowledge and education, because at the end of this panel, I hope that we only won't highlight the issue, but we'll also be able to tie it together with some of the ways we can deal with it. So thank you very much for sharing with that. Now I'd like to go to Kenya a little bit and ask Allan. Allan, I know you're a human rights lawyer. You presented yesterday you articulated very well the case in Kenya, where the patients were imprisoned, and and that you and KELIN have been working. That started off your journey in TB. Now, how does human rights, upholding human rights, is that at all possible within the TB scenario? And how different is the stigma and discrimination between the people living with HIV and TB? Is there a comparison? Is it completely different? I mean, this is, from Kenya, if you could give us that perspective.
Thank you very much. I think to start off with the last issue, the stigma is the same, because the stigma is fueled by the issue of fear of people getting infected, and that's what has brought about the stigma around issues relating to HIV. So that particular fear makes us act in a certain way to be able to try and protect ourselves. And in doing so, we don't realize that we are either stigmatizing or discriminating people. In addition to the example that I gave yesterday, and just to bring out the aspect of stigma and discrimination and how we've tried to address it, we had another case, again, reported in the media, of a lady with extensively drug-resistant tuberculosis. And it was reported in the media that she was not getting drugs from the government, but she was being given prescriptions to go and buy the medicine. Now, for us, it didn't make sense. You have the most dangerous form of TB. The government is not providing you with the medicine, but is sending you to a pharmacy to buy the medicine, and we clearly thought that was absurd. So we reached out to the family of the woman and found out what was the issue and approached her. And when we mentioned that, why don't we litigate on this matter, she was like, my employer doesn't know I am out of work. I took leave as normal leave. If I go and litigate, it's going to be a problem. And I would not want people to know about my TB status, and eventually it may be linked to my HIV status, because she hadn't disclosed to many people. And again, the whole perception that given that we didn't have clear guidelines on how the government should deal with XDR TB patients, she saw that what the government was doing to her was a favor, and that if anyone challenged it, the government could withdraw her treatment. And so for that reason, she was very apprehensive when you said, we want to take action against the government in terms of being able to address her to be able to get the treatment. Well, we finally convinced her. We didn't go to court, but we wrote an advisory letter to the Minister of Health saying that we've come up with this case. We've got this lady who has TB. She's not being attended to. No one knows where she's getting her medicine from. The medicine even that's being prescribed, some of it is not registered in the country. What can be done to address this issue? So when we did release that letter to the minister and to the media, then the government stepped in and said, no, we are providing treatment, the Global Fund is helping. And then the next discussion now was, what is the policy in place? Do we have a policy so that if we have another person, we actually call the lady Mrs. X to give her anonymity. So he said, if we have more Mrs. X, what needs to be done? So that's what sparked off the discussion for us, and we began having different ways to address issues around TB, HIV, and human rights. We, building up on the cases of the people who had been arrested that I spoke about yesterday, we realized the importance of trainings of, one, the communities, of the government officials, for those who are willing, because not all of them are willing, and also the other people in the other arms of government, like the judiciary, the lawyers, in terms of them understanding and appreciating what's important around TB issues. We also began using dialogues to be able to bring all these sets of people together for them to see how their chain reaction of action leads to violation of human rights. So if the magistrates understands by taking someone to prison, they're making the TB situation worse. by the doctor understanding that if you don't give sufficient information, a patient can fail to adhere. So those dialogues have equally been able to try and help stimulate discussions around this particular issue. We've also engaged in advocacy, like what we've done with Mrs. X. When we pick up an issue, we flag it to the government by writing letters, getting other partners to join us to be able to do that. We've begun doing research with the support of Stop TB to document human rights violations that may be happening within TB programs within our country, how patients are being treated by doctors, how healthcare workers may be facing challenges to provide services to TB patients because the government may not have provided good working conditions for them. And finally, we also are litigating, as I said, but we only use litigation as a last resort. And we've opted to use litigation to address the issue of forcefully isolating patients in prison, because all our discussions with the government have completely not materialized, and it's only left to the court to be able to address this. So as Blessy said, and as I conclude with what the Kenyan scenario is that it's no different from what we have with HIV. It's only that even after one gets cured with TB, they still do not want to be associated that they had TB at some point. And that's one of the difficulties we then have in terms of forming support groups, because in the case of HIV, it's slightly easier, but in the case of TB, once is healed, they want to go back to their normal life and not to be disturbed all the time. So it is important to address human rights and use a rights-based approach in dealing with issues of TB, HIV, and generally any other disease, because that's pretty much important when you factor in the principles of participation to ensure you get the right programs that allow you to treat the patients well. When you factor in the whole principle of accountability, you know who's responsible and what they need to do in terms of a duty bearer and the right holder. When you look at the issues of non-discrimination, you'll be sure that when you're rolling out your services, you're not doing it in a manner that would be discriminating against people. And of course, when you empower the people, you get them to demand for what they need and what they need to be able to get. And we should then shift our approach, which we've had both in HIV and TB, where we look at it from a medical perspective, but now we need to link it to rights. When a woman who has TB comes to your clinic and her rights have been violated in terms of being beaten, in terms of being subjected to violence, yes, you can address the TB, but you need to know who else can address that aspect of violence. Who else can address the aspect of her being sexually abused? Who else can address the aspect of her being treated badly at home, so that we link whatever we do towards issues of right and not see that we're just giving a service to a person, but we're making them enjoy their right to health. Thank you.
Thank you, Allan. That's very helpful, and I think I would like to pick up on the point of a holistic approach rather than and I'd like to come back to you on that. Prabha, the next question maybe for you. In your work, TB is still very much seen as a disease of poverty, even though, as I said yesterday, we are seeing a change in that, but it is still very much a disease of poverty, and due to a host of socioeconomic determinants, and it's also associated. Poverty is associated with poor treatment outcomes. And I know you work with a lot of women and children especially. So in your experience, what has your experience been with regard to stigma and discrimination, and how does this, fuel that, poor treatment outcomes for TB?
Hello. Yeah, thank you. Before I begin that, I would like to take on with what he said. This happened, I think, 4 years back. I got a call from my patient somewhere at 9:30 at night, and she was a TB HIV co-infected case, and she calls me saying that her husband had passed away, and her in-laws were actually troubling her, and she was forced to go out of the house at 9:30 p.m. And she calls me, and I have associates in the legal cell, and there is an NGO working for legal cell. So Majlis, I contacted them, and I said, this lady really needs help, at least for this night, and what best can we do? And unfortunately, I didn't have access to anyone very close to where she was staying, because she was staying in a remotest area in Bombay. for this, I was shocked by what the professional shared with me. She said, I can understand if it is any kind of an abuse. Prabha, TB, HIV, even if somebody like that would land up, I would send them to you, and you're asking me. And what he said, like, here the question is, who's going to address this? Who's going to take charge of the situation? So are we looking at people who are working for TB or HIV, or are we looking at women? I told her she's a woman. You know, in the first place, she's a woman. And the status as what the health conditions come later. But that's a very sad story. And I couldn't do much for that woman. Again, we started this project. Alert India had begun TB control activity, I think 10 years back. When I started working, in fact, I had worked on the project right from the beginning. It's more like my baby. When I started work, 3 years later, I was too premature when I started my work. But 3 years later, when I did a study, as to I just tried to understand the sex ratio, where I found that it's more of men and not many women are, I didn't find many women patients. Like, then I said, okay, there is a problem in reporting. So then I understood, like, the kind of case detection that was happening in our activity. It was more like conducting public level campaigns, you know, IEC programs in public places, in open markets and other open, where there are a lot of men basically. So then that came to an understanding that it's maybe because we are doing it only in the public places, we are not getting women. And that is when I changed the strategy as to actually going door to door. And that was quite an advantage, because when we started actually going door to door, and that is the time women were available at home, and we did track a lot of women cases, and definitely that showed a rise in the women case detection. But I'm not trying to say this is a very small part where I'm doing, but I think there could be many women who are untouched. But actually, I want to touch upon another thing, is the health-seeking behavior. Like, many of the women, firstly, they don't even understand there's a discomfort, because they are so conditioned to their living, like they live that kind of a mechanical life. So there is no one whom they even share that they are actually undergoing some kind of a discomfort. And very often we've found our women, even I would say, like cases like even in the MDR cases, or even cases that have been, you know, they've taken a long time for reporting, where all these women would have tried all kinds of traditional home-based remedies, just because one is there is no knowledge about anything. There's no awareness. Right from awareness, like they don't even know that it's a disease, like they are suffering from some symptoms. And also there is no awareness that there is a free facility available in the community itself. All that they are aware is, they just know that there is some, only about the reproductive part, like, okay, if you get pregnant, you can go there, and there is a prenatal and antenatal care. Apart from that, they didn't even know that there are these facilities even available for them. And especially the stigma. Basically, I think many of women seated here would agree, like, it's a dual stigma, because as women, I think all of us go through a lot of challenges. And to be affected by TB is a dual kind of a stigma, where a lot of discrimination. Even I would say, when we go for counseling or even home visits, you know, the first, the family counseling sessions, like, many of the women, most of the women would not even want to talk, because she doesn't live with people whom, you know, she has been, it's not her maternal home. So she would say, I'm okay. And she would look at her in-laws, you know, because she can't complain anything about her illness. She can't talk anything about her discomfort. And so, like, even a small thing, like, you know, you can't even express what you're going through. Like, and then we found that counseling session was so difficult. And sometimes it's not possible for the woman to be always available in the dot center, because she would not even wait after taking her medicine. In our centers, we have almost 60% of women who are doing domestic work. They're all domestic workers, and many of them, as we know, yesterday we saw the kind of paralysis that happens in their in the economy. Like, some of them have been forced to leave their jobs just because the employer learned that they are suffering from TB. Except for some cases where we have personally convinced the employers and we got them back. But I would say it is just not a social. It's more of a psychosocial, economic, and even a cultural barrier. Because somewhere I feel women have been mentally conditioned. Maybe it's like our upbringing, or I think it's a typical Indian kind of an upbringing where maybe they don't even express, even to fight for your right. Like our friend was saying in the morning, like we had an advocacy meet where people, it took 8 years for them, 8 years to start MDR treatment, but they were so happy that at least after 8 years they got it. So it is like, it's a matter of, okay, finally, like it's your right, you need to have it, and you have every right to voice your opinion, and you can have what you want. And this has not been actually, I think, driven, or it has not been a part of our upbringing. Like someone said in the morning, counseling is never a curriculum in the medical science, in the academics. Like, so similarly, I think these little, there has a lot that has to go into even the cultural part. And of course, with reference to children, I think they are the most affected, because even now, I'm sorry to say, I still have certain government officials here, but still there are some children who have been deprived of prophylaxis. I think that's the saddest part. And it's like when knowing that there is a drug-resistant person or a active positive case in the family, but still if the child is deprived of it, I think, and we have fought a lot with the RNTCP, and also like a lot of advocacy where I've just begun my work, and we have started a small group. Like, I won't say it is an active kind of a support group. We have started something in a very small way with a few TB patients, and as our friend said, unfortunately, even cured TB patients, like for them TB is history. They don't want to talk about it anymore. Just imagine what kind of a stigma it could be then, like if they don't even want to talk about it again. So getting cured patients together and then forming a group, and we are fighting it out. And of course, we are also doing a lot of nutrition for women, for both men and women, but definitely with a special emphasis to women.
Thank you, Prabha. That was very interesting, what you said about childhood TB. Somebody recently at a childhood TB conference said, if TB is an orphan, childhood TB is an orphan of the orphans, so that's how distanced it is. So I'm glad you raise it. Anjali, now coming to you, I know you're very passionate about working with migrants, and that has been your experience. You worked in Nasik, and you bring that rich experience to your students as well. So, India has a huge number of migrants. We know that both, internally and transnationally. Now, what sort of barriers do the migrants face in terms of accessing care, diagnostics, treatment? I know you did touch on it, briefly yesterday, but if you could just share with us, what sort of barriers there are, and very specifically to stigma and discrimination, if you could highlight that as well. And then maybe just say, from your experience, what would work best in that situation to address that?
Sure. As I shared yesterday, migrants, comparatively to general population, and more specifically even with slum population, migrants are more likely to get TB infection, and mainly because of their crowded living conditions and also their work conditions. But I would say before that, I have experienced this, that the health seeking behavior among migrants is very less, and I would say that the awareness about their own health, number one, is very, very minimal. Second thing is the tobacco and alcohol usage is very high among them. It could be because of their nature of work. So that is very important risk factor among this group. Second thing is awareness level. First is awareness about their own health, about their diet, about their living conditions, how that can be improved. That's very minimal. Second thing is awareness about existing health services, what are, as you say, freely available in the community level, and how that can be accessed. It's very, I mean, that's almost negligible. And I think that could be because of their migration status, because I have spoken to many, many migrants, and it's very clear impression among them that, okay, I'm not part of this city, I'm not the citizen of this town, and so it's not my right to go and access the services. And some migrants have experienced this personally, because I mean, I have very touching example. There was a Bihari worker in Nasik, and he had a dog bite, and he went to the civil hospital. So the nurse made some basic dressing. It was on his feet, and she said, for the rabies vaccine, I mean, you have to go back to Bihar, because we have very limited vaccines here, and it is for our own people. So you have to get to Bihar, your local village, and get it. So that kind of discrimination workers face, I mean, not only in TB, but health in general as well. So, but that empowerment is absolutely not there, that, no, it's my right and I should get the medicine. That empowerment is absolutely zero among migrant workers. So that is at migrants level, awareness level. Second thing is, even if some migrants are aware about treatment and about the testing mechanism, the distance between their work sites and the facility level is so long, and the transportation is the major problem for them. Sometimes they have to lose the entire day in going and accessing the service. So distance, transportation, and the long waiting hours is another important barrier. I mean, these three are very important barriers in accessing services. Another thing, another important factor in the whole barrier issue is employers' attitude. Many employers don't allow their workers during the work time to go and access the medical health services. And generally the health services facility timings and work timings, I mean, there is always a clash. And no any OPD will work after 6 p.m. or maybe early in the morning. So workers generally miss out this opportunity to go and access the services. Workers, I mean, in workers' health point of view, I think employers are mainly responsible for not providing occupational safety, and particularly in context of tuberculosis. These migrants are basically engaged into a bit hazardous work conditions, mainly who are into construction, stone quarry, furniture, agriculture. The pesticide use is quite high. And I have seen, I mean, all of us are aware, I mean, only in some, organized setting, for example, big construction companies, they provide gloves and helmets and masks, but that doesn't happen in all sectors regularly. And that is putting workers at risk for not only to tuberculosis, but also to, other respiratory infections. So employers' role, I think, is very important in this whole picture. And third one is, as I already discussed, the migration status. I'm not talking about only in testing context, but in treatment thing. I was discussing with the RNTCP person, the WHO person who I think left. He was saying, okay, intervention is good, and at one level or second level intervention may be successful, but what happens if the migrants are changing their accommodation and they're shifting to other town or other state? The dual card mechanism, as I discussed yesterday, it is available at some level, but it is not functional fully. I mean, the official says that the system is there, but I haven't seen it's functional or it's actually being used by workers. So that definitely needs to be strengthened. And only the dual card facility will not work. I mean, there has some smart card based system which can be, that treatment stages or whatever treatment was given at one level, at one location, must be, get monitored at the second level where the worker is going. So only dual card will not work. There has some, smart card based system. And now government is saying we will use UID for having linkages with all public services, including health. So this can also be promoted, but I don't think government may be able to do it immediately. I mean, some a kind of pilot needs to be happen on smart card basis treatment for migrants in tuberculosis. So these are some of the barriers, I think, based on my experience. And if you want to overcome these barriers, I think generating awareness, not only at community level, migrant community level, but also at employer level and also at health system level is very important. Because in barriers, we all know that, RNTCP or DOTS, they doesn't provide outreach. They may provide outreach, but to a very certain locations. But the migrants are, scattered all over the city, maybe sometimes just outside the city. And that mapping needs to be done if we really want to cover migrants. And I think that is very doable. I mean, if we can achieve polio immunization universally, why not tuberculosis? So that outreach is really, really important besides awareness and empowerment of workers. And employers' participation is very important. And I think Labor Department can be, bring in the picture for that. Another thing is, I think personally, I mean, besides community empowerment, awareness, employers' contribution, system strengthening, there has to has an integrated approach. I mean, as we just said, there has to be a holistic picture. I mean, we can't work in isolation, just RNCTP or workers. Maybe it can be tied up with ICDS for better nutrition of workers, because as you said, I mean, they all are poorer. I would say poorer than poors, okay? So the food security and nutrition is another important issue for them. Labor Department can be brought in for effective implementation of labor laws. And also maybe some private players, like, there are Red Cross.
Specifically to reduce stigma and discrimination, I mean, some of the things that have come up is education, knowledge, and how do you remove fear? Again, that is with information and a rights-based approach. And you also talked about advocacy, the role that has to play, and the importance of documenting things. And of course, as a last resort, of course, there is the legal way litigation. But so, a lot of what I'm hearing is the first simple solution, awareness, education, increasing the knowledge. Now, I'm not saying who should be doing it or who is not doing it, but generally looking at TB in India, do you think there is enough of this out there for a common man to understand TB? Do you think there's enough information, knowledge, awareness about TB in India? Yeah.
At the moment when we take the common public, there is not much awareness on these things. As somebody has pointed out today morning also, we don't have much of the publicity with regard to these things. Where it is available. The free services are available. When we started our interventions, when we went into the communities, telling about them the modes of transmission and what they should do also to prevent transmission, and also where the free services are available at the government health sector. People are not aware of such things. So what it is required is, it needs an intensive media advertisements has to come, and also at the community level also, at the schools and the public health places, and even local panchayats has to be involved. What we did in our program is we have involved the gram panchayats, village level, local self-governments also are involved in this program, and they are also working for wherever there is a stigma case. The Sarpanch used to go there, and he also worked with the family and the community, whoever is involved in that. So such type of intensive campaign, what we have taken up previously for HIV, such intervention has to be taken up at tuberculosis.
So, so what I'm hearing is that knowledge, information reduces fear and empowers people. So that's something I think very concrete that could be done by everybody, not just the program, but civil society organizations, non-government organizations. I think everybody could do that. The other thing I hear many times is that there is no ambassador for TB. in India. You know, like if you look at polio, we had Amitabh Bachchan saying, you know, teen bund, you know, meaning 3 drops for life, which had a tremendous impact. I mean, Indians are desperately Bollywood worshipping people, whether you like it or not. And so many times I hear that, you know, for TB there isn't anybody. And it isn't for lack of trying. I personally have also tried, but none of the Bollywood stars want to actually talk about it. You know, even if they've had TB, I know someone, a young actor, who's had TB, had issues, went to Singapore, got treated, come back, but doesn't want to talk about it. You know, so even there is this whole issue. But recently what I heard is that for Mumbai, Amitabh Bachchan has actually come forward and said that he would be the TB ambassador, but only for Mumbai. I'm not sure why, but why can't he be for the whole country? But then others said, oh well, he's lost his charm anyway. No, but I think that... so I think that is another issue that people find. So I want to ask you, Prabha, do you think having an ambassador would really, you know, bring TB, would highlight TB and the issues and bring down the stigma?
Actually, very right, Blessina, because even we've been thinking on those lines. Actually, TB, it's just not. Cured. They don't want to be associated with TB once again, because for them TB is history. I think there is a lot of stigma to this. And secondly, the transmission part. Like when you say you're a cured TB patient, still people look at you like, okay, you may get TB once again, or maybe sitting with you, talking to you, I may get TB. So I think these are the, you know, the psyche. Like one has to work on those lines. And probably, because till now, I think with HIV, we have, you know, it has gained a huge momentum because we have had ambassadors, we have had people talking about it. I think it's high time, like maybe if we have someone who take the initiative and come up, just not restricting to Bombay, but you know, in a very big way, definitely it will make a difference.
Yeah.
But recently, Aamir Khan hosted a show, Satyamev Jayate, and tuberculosis was his agenda. I think such programs may help to, you know, raise greater awareness. And I like his punchline of the program: either we will all sail, or either we will all sink because of this disease. So that greater awareness has to be there. I mean, it's just a thought. Maybe if, Prabha, you are trying to have an ambassador on board, you may approach Aamir Khan. He will be glad to.
Actually, I'm very sorry to say, because the kind of wave that created in Mumbai amongst RTB control fraternity and also amongst patients, it's like after seeing that, because we had messaged everyone not to miss the program, actually it didn't have a very positive kind, because they felt that there was a lot of talk or a lot of hype about TB, and people actually feared. Probably, I'm sorry to say that, maybe that is not the effect, the impact, what they expected that happened in Mumbai at least. Because all of you know Mumbai is a hot spot, and especially there was so much talk on drug resistance, like not much was mentioned about nutrition, and not much mentioned about, though they did have some success stories being, you know, they showcased, but still the kind of fear and the kind of stigma, I think it's not helped us maybe the way we wanted.
Should respond as the TB community to the program. And say, Allan, I'm going to give you the last chance before we open it up for discussion. Now, you've been with us for 2 days, and I think you've got a little glimpse of what India, with its huge burden and other challenges, is. If you have to, you know, give us one, I know it's impossible, but try. You know, one suggestion in moving forward in stigma reduction, you know, in a rights-based approach to TB. or maybe I'll say two things. Can you give us two things that we could do as a country? And I'm not separating government and non-government. I mean, it's for all of us who are in this fight together.
I think the first thing I'll obviously suggest is we need to get everyone to understand when we talk about what's a rights-based approach. And for me, it would be it government, be it civil society, be it religious leaders, be it the Bollywood stars, everyone needs to appreciate what does the rights-based approach mean. Because once you understand the rights-based approach, you will see the value that will have to your programs in terms of what you're trying to address with TB. So you'll find you're not only addressing TB, but you're addressing other health issues and the determinants of health that I can't remember the name of the colleague who was asking Anad about what he's done with the environment and everything. It'll help address all those issues, but only if you do appreciate what the rights-based approach is. And the rights-based approach take into account the principles I talked about: empowerment, participation, accountability, knowing who's responsible for what and who deserves that particular right. So for me, it's rights-based, rights-based, rights-based. How do you get it infused in what you're doing as a government, as a civil society, as an individual? Let's take it as a way of life when you're dealing with this issue, then that would be a very important step. So that's the one. And the second thing that I'd recommend to the Indian colleagues, both in government, in civil society, and in any other sectors. Understand the rights-based approach, embrace it, and put it into practice so that we are all talking to each other and we are all meeting one goal. Thanks.
It's very important for us, kind of not to make it us and them as against the government, the program, and us, because I think we need to work together. And I think, upholding patients' or affected communities' rights does not go against the medical fraternity. Is something that I think we need to help understand, because I mean that's the feeling that if the patient demands for rights, then that's going against the doctor, but that's not how it is. So I think it needs a really collaborative partnership. So with those, I'd like to open up the floor for a few comments or questions. And okay, I see 3 hands. Yes. Please address the question to, please mention who you're addressing it
Actually, it is not a question.
It's a comment. Yeah, and also introduce yourself. Yeah, it's working.
Okay. It is not a question, but it is like suggestion. In India.
Introduce yourself, please.
Yeah, I am Rashmi, Secretary, Vasavya Mahila Mandali, where Keerthi is representing our organization. In India, there is, for the HIV/AIDS, there are parliamentarians forum and legislative forums at national level and for every state level. That made a big difference because when we are talking like this, we should also make people's representatives to be part of these initiatives. Then they will talk whenever they go outside in the speeches and all, they used to talk about HIV first. Like that, we should make them to talk about TB also, so that it reduces stigma and discrimination and also nutrition. I think already existing forums are there. Our team should make it possible to include, to talk about TB and giving correct information to speak about that in the forums, and also in their consciences whenever they are going. No, if they tell, many people, they will listen to them. Therefore, the followers are ready to listen to them.
I think that's just to respond to that. Chapal is not here, but both Chapal and myself were part of a group that set up. It's not called the Parliamentarians Forum, it's called the National Tuberculosis Forum, which is actually a group of parliamentarians. But the problem is that we don't have a TB United Civil Society in India to appeal to them. So all of us are doing bits and pieces. But I hope that we can all come together and kind of create that kind of demand and pressure. So there is that already. We can give you the contacts. It was launched with the then Delhi Chief Minister actually speaking about TB. So that's already going on. So thank you for raising that. Yeah, there's yeah, this gentleman, then this.
Thank you. I am Dr. Ranbir Singh, DTO New Delhi district. Just I want to say that while doing counseling of these TB patients during the treatment, it will be appropriate if we emphasize on the patient that the TB is an airborne disease. Okay, you got TB, not your fault. Because someone had TB and he did not care. So it is not your fault you got the TB, but now if you don't take treatment and don't have proper etiquettes, cuff etiquettes, you will spread to the others. So this type of counseling and message should be given to the patient who are put on treatment. That is my suggestion.
Who would you suggest gives that?
It may be at every level, from DOT provider to STS to MO and D2, right up to the health system. Who is giving the treatment? Yes.
Thank you. The gentleman at the back.
Just information to all of you about the Goodwill Ambassador. As we know, for the HIV/AIDS, South Asia already started the Goodwill Ambassador for HIV as a Shabana Azmi last 5 years. And recently, the South Asian Association for the Cooperation announced the Goodwill Ambassador for the Ajay Devgan and the Runa Laila from the Bangladesh, the two different Goodwill Ambassador for HIV, and now started from the tuberculosis also. So very soon maybe Ajay Devgan is the Goodwill Ambassador for Southeast Asia, and we are initiating that initiation from the last year. Thank you.
One of the DTOs in Delhi. I would address this question to all the panelists. How about using the services of a cured TB patient, who can be much, much more important than the medical officer, than the DTO in spreading the this awareness about the disease and etiquettes about the cough? Because I think that we have been doing it earlier in our premises, in our clinic, in our community meetings. We are doing it. We are utilizing the services of cured TB patients.
That's an excellent.
Tuberculosis, and also once they are cured also, they are coming forward and they are sharing their own stories and experiences and challenges.
Yes. Yes.
Idea, but the challenge we must be able to live up to is to be able, as we work with our patients, to help them appreciate why it would be important for them to share their story or to support other people. So in the process of treatment, and as they come towards the part of getting cured, then we should be having those discussions with them for them to appreciate and see that when they share their story or speak to other people, they'll be much better off to convince the people on why it's good to stay onto the treatment, how to survive the side effects, how to deal with the challenges. So we need to encourage them, both as healthcare workers, both as civil society people. How do we get the patients to be encouraged to be part of these discussions and to still want to serve towards seeing others not getting TB?
Patients, we invite them as resource persons in our patients meeting, and they also, that's a very good mechanism where we can involve the cured patients.
In our case, we are
using when the person who was treatment is healthy again, and I think that's when you can actually use the services. So, no, that's a very good point that you raise. Yeah.
To add to the thing about the political fraternity, awareness of the political fraternity. Last year we were organizing a MLA meet in our area. I come from Uttar Pradesh. So in that meet, you would not believe that whenever we go to the legislative assembly and we met the legislators and we said that we are organizing a workshop for you people to come, and the basic focus is the tuberculosis control. So they were astonished with the fact whether the tuberculosis is still existing there. So, and we met around 20 to 30 people from Legislative Assembly, and you will not believe only 4 came to that meeting. And after that meeting, now what scenario is there? This is the year 13-14, financial year 13-14 is passing by, and the year would end after 3 months. But still the project implementation plan is not implemented in the districts. Now, it has not come from the state to the districts. From Delhi, it has come to the state, but it has not come to the district from the states. So this is the thing we are facing.
Yeah. I think it's very important for us to target our advocacy efforts, at the political leaders, at the decision makers. And you're very right. I mean, we also did over 2 years advocacy with parliamentarians. And the number of MPs that I've met, they said, Madam, why have you come to talk to us about TB? We've eradicated it. I said, I think you're mistaking it with polio. So the knowledge is so, yeah, the knowledge is so low. And you can't blame them. I mean, so I think if all of us took that on and did wherever we are, the local MLA, the local politicians, invite them, educate them, and they have been extremely, extremely willing to come and learn. I mean, some of them, I remember somebody said to me, I have been a politician for the past 30 years. Nobody has ever talked to me about TB. So I think the fault lies with us as well, that we haven't reached out. So, but I think so we need to target our advocacy efforts at different levels and that will also indirectly bring the stigma and discrimination down. The more the people talk about it, the less the fear. And this whole dark, kind of alley, kind of a unknown thing that TB is right now, will all get, kind of lit and cleared, because that's how it is. I mean, when you have the symptoms, what do you know? You don't know where to go. You might, if you're lucky, you might see a very medicalized poster that says if you have 2 weeks cough, go to a DMC. What is a DMC? How many of us know what it is? So I think, so there's all this, kind of fear and unknown when it comes to TB. I think we need to talk about it a lot more, demystify it, demedicalize it, if we want our people who are suffering with TB, which is about 2.3 million every year. If we want, I mean, can you imagine if every one of them was empowered? We wouldn't be here having this conference. So I think it's a challenge for all of us as we go out from here, that we remember to have a rights-based approach to demystify TB, to demedicalize TB, that it becomes something that we all can confidently talk about because it's totally preventable and curable. So with that, I'll say a big thank you to our panelists. You still want to have a
Actually, I missed it when I was sharing my experience with women. Basically, my request is that when you conduct capacity building, especially in RNTCP, when you conduct capacity building, especially, I think there should be some element of gender sensitivity. Unfortunately, if you see TB patients, women TB patients, they get infected in the in their reproductive age. So I would request that if some kind of capacity building or in terms of information related to that, and how could they deal with women TB patients, if that has been, I mean, it's been, they have been trained how to communicate to them and the consequences, it would really help in counseling women patients.
Thank you very much, and thank you for all your comments.